Thank you very much for the opportunity to speak to you today. Topic of my talk will be advances in the management of spinal stenosis and degenerative disc disease, as well as spondylolisthesis. As Dr. Feldman already went over, spinal stenosis is a very common condition in the United States, with a large proportion of the patients requiring surgery over the age of 65. The symptoms, in summary, are primarily neurogenic claudication, which include leg heaviness, weakness, numbness, and pain. In certain patients, especially patients with instability, back pain is also a major component of their symptoms. As Dr. Feldman explained, the spinal canal is usually more open to the nerves in flexion, and pain is usually relieved with sitting down. The causes of spinal stenosis are very numerous, but to summarize them, it's any condition that can occupy the space of the spinal canal. And that can include herniated discs, arthritis or degenerative disc disease, spondylolisthesis, fractures, and other causes. This is a very similar slide, but on an anatomic level, spinal canal. This is a T2 weighted image of the axial spine. On the left, which is a normal image, you can see a wide open canal. The facets at that level are relatively normal, with no significant osteophyte or bony spur formation. And the image on the right shows a severely narrowed spinal canal with near obliteration of the spinal canal by a bulging disc and bone spurs from the facet joints. All these conditions combined lead to spinal stenosis, or narrowing of the spinal canal. And one of them that we'll focus a little bit more is spondylolisthesis. Now, to further understand spinal stenosis, we have to understand where it occurs. And the spinal cross-section area of the spine, the three main areas that stenosis will occur is the central area, as outlined in blue, the subarticular area, which is the area under the behind the facet joint, and that's in pink and green, and the foraminal region, which is yellow. And the location of the stenosis will help determine the type of treatment that will be necessary for the patient. The management of spinal stenosis is varied, and as Dr. Feldman mentioned, the conservative treatment is usually the first line of treatment for all these patients. And it includes anti-inflammatories, physical therapy, chiropractic care, bracing. A lot of times activity modification and weight loss are very important. Once the patient has failed these, the next line in management is the epidural steroid injection, as well as selective nerve root blocks. And these can be usually performed up to 3 times in a year. And it involves placement of a needle in the epidural space, usually performed under local anesthesia. If all these conservative treatments fail, then surgery becomes an option, and surgery can vary from a laminectomy or an X-stop procedure, as Dr. Feldman described, and occasionally a fusion procedure is indicated. Fusion can be performed traditionally through a posterior approach, but newer advances in minimally invasive anterior surgery, as well as direct lateral procedures, are also available that we'll talk about. A little bit about spondylolisthesis as a common cause of spinal stenosis. What it is an unstable movement of the vertebra, of the superior vertebra on the inferior. It's usually caused by a degenerative fracture or instability. The fracture in question is the pars interarticularis, which is in the posterior elements of the spine. As a result of this, the superior vertebra slides forward and causes abnormal motion between the two vertebrae. This abnormal motion puts stress on the nerve roots and on the facet joints, leading to arthritis. In addition, patients with spondylolisthesis a lot of times have symptoms of back pain. Traditionally, classic spinal stenosis, patients do not have any significant back pain. Most of the pain occurs in the legs, worse with walking or standing. Patients with spondylolisthesis, they have advanced degenerative disc disease, and symptoms of back pain occur that can happen with sitting or with standing. This is an anatomic slide, which is a slide through the sagittal spine. This is a patient with a grade 1 spondylolisthesis. You can know the nerve root in the foramen superiorly. As a result of the abnormal motion between the two vertebrae, the disc fragments protrudes posteriorly and significantly narrows the neural foramen. In addition, this abnormal motion causes increase in forces on the facet joint and causes bone spur formation and hypertrophy of the facet joint. Combined, these two findings result in severe narrowing of the neural foramen and compression of the nerve root. Traditional surgery, such as laminectomy, a lot of times does not adequately decompress the neural foramen. In addition, laminectomy does not address the issue of instability or the abnormal movement between the vertebrae. So we'll talk about a couple of the cases and further go into the diagnosis and management of spinal stenosis. So this is a 57-year-old woman that came to me with approximately 2 years of back and leg pain. She had significant radiculopathy with numbness along the lateral left side of the leg and weakness in the L5 distribution in ankle dorsiflexion and EHL. Symptoms were present with sitting and with standing. Of note in her history, she had previously undergone microdiscectomy at an outside facility approximately 5 years ago. She initially had good resolution of her leg symptoms, but over the next 3 years, her symptoms worsened and she began to experience more back pain. She had tried extensive physical therapy, anti-inflammatories, and steroid injection, including nerve blocks. In the initial evaluation, after conducting a physical exam and a neurologic evaluation, X-rays are obtained. You can note here, more focused on the AP and lateral X-ray, there's approximately a grade 2 spondylolisthesis at L5S1, which is abnormal slippage of one vertebra on the other. In addition, the disc space at L5S1 is severely collapsed and leading to severe back pain. Part of the evaluation of a patient with spondylolisthesis is to obtain flexion and extension X-rays, and these help the surgeon determine how much movement occurs at that level and how much the abnormal motion between the two vertebrae causes the patient's pain. These are T2 weighted images of the axial and sagittal spine in this patient. You can note on the picture on the left, there's actually a significant amount of room in the central area of the spine. And therefore, a traditional procedure like laminectomy might not adequately address her symptoms. In this patient's situation, most of the compression occurs laterally on the left side at the subarticular region and in the neural foramen. Also in the picture on the right, you can note the spondylolisthesis at L5S1. Now, she does have degenerative disc disease at other levels, but her symptoms were primarily L5 in nature, which is the nerve root that exits at the L5S1 level. So this patient underwent an anterior lumbar inner body fusion through a minimally invasive approach, as well as a posterior percutaneous pedicle screw fixation. The pedicle screws were supplemental fixation due to the high degree of slippage at L5S1. And you can note on the two pictures on the left is the correction of the spondylolisthesis. And if you look at the back of the vertebral bodies at L5 and S1, they nearly perfectly line up. During surgery, the implant is placed to distract the disc space, and this distraction reduces the spondylolisthesis. In doing so, the neural frame in the area where the nerve exits is greatly increased in size. This is outlined in yellow stripes. So it went from preoperative on the left to postoperative area, and this area is where the nerve is getting most compressed. So a little bit about anterior inner body fusion. It is done through a retroperitoneal approach, usually with assistance of a vascular surgeon. During this approach, a small incision is utilized, just big enough to get the surgeon's hand into the abdomen, and the retroperitoneal dissection is performed, moving the abdominal contents to the side. In addition, the aorta and inferior vena cava rest directly anteriorly to the spine, and these have to be mobilized as well by the vascular surgeon. And once the retractors are placed, the disc is completely removed, and in its place, a large graft can be placed. This can be from a cadaver or through a highly dense plastic called PEEK. In addition, percutaneous screws can be added at the surgeon's discretion if they feel there's a lot of movement or instability at that level. The advantage of this procedure is that it avoids doing the traditional posterior surgery. There's minimal trauma to the muscles and the bone. The dissection is all performed in between muscular planes, so no muscles are cut, during the exposure. It allows for complete visualization and removal of the disc, and therefore a large implant can be placed and correct the spondylolisthesis. Well, you can see this is a very busy slide, and there's quite a few important structures in front of the spine, and this leads to the disadvantages. There's significant manipulation of the blood vessels and the organs, and vascular injury is the most serious and potentially devastating risk of this surgery. Some studies done about anterior exposure in the early years, in the first study in 1993, you can see the vascular injury rate was very high, at 15.6%. Common iliac vein tears were being the most common. As surgeons have become more experienced and familiarized with this procedure, the complication rate has decreased, but it's still quite significant, nearly 2%. Due to these high complication rates, alternatives were sought for achieving spinal fusion with less trauma to the spine or less risk. So a procedure called the XLIF, which is a lateral inner body fusion, has been developed. It's a lateral approach to the spine. It also utilizes the retroperitoneal space, but instead of going anteriorly, plane is made just lateral to the body. It utilizes neuromonitoring to gain access to the spine from the side through the psoas muscle, and the psoas muscle is directly lateral right here. The advantages of this procedure is that it is a minimally invasive procedure. A large interbody graft can be placed, and the importance of the large graft is that it can help restore the degeneration and the disc collapse between the two vertebrae. And there's no ligamentous or bony structures that are resected, as would be in the posterior surgery. The disadvantages is that it cannot be performed at every level. At L5-S1, the iliac crest gets in the way of the exposure, and the alternatives to the surgery have to be sought. And as in the first patient, a lot of times at L5-S1, an anterior exposure is necessary. Also, the dissection goes through the psoas muscle, so transient hip flexion weakness and anterior thigh pain can happen. Usually it resolves by 4 weeks after surgery. The advantages of this procedure is that it's much shorter, much less traumatic surgery. Average time for the surgery in this study was about 74 minutes. It can range 1 to 2 hours. Patients do significantly better. They're able to get up 1 day after surgery, and usually are discharged in 1 to 2 days with significantly less risk. The typical blood loss in this kind of surgery is less than 30 cc's. The way the surgery is performed, the patient, after being placed under general anesthesia, is positioned on their side in the operating room, and then the table is bent to allow for the ribs to separate from the iliac crest. And this allows for visualization and space for the surgeon to work in. Under X-ray guidance, the disc is marked, and the skin is incised. The usual procedure involves performing 2 incisions. The one on the right here is directly lateral over the disc space, and the one posterior allows the surgeon access to the retroperitoneal space safely. Once the retroperitoneal space is accessed, the gentle finger dissection allows for mobilization of the abdominal contents, and then dilation can be carried down directly onto the psoas muscle. In this picture, a probe is placed into the disc under direct visualization. The probe is placed under neuromonitoring to allow safe passage of the probe into the disc space. And then dilation is carried out over this probe so that the psoas muscle is not violated. It is gently stretched with serial dilators that allow for the muscle to be spread atraumatically. Once the dilators are placed, it allows for visualization of the disc. Now, the benefit of this procedure is that even though it's a minimally invasive procedure, the surgeon still has full visibility of the discs and the full working area to perform the procedure safely. Once the complete disc is removed, interbody graft is placed, as in the picture on the right. The graft is usually packed with either cadaveric bone or calcium crystals in bone morphogenic protein, which helps stimulate growth between the two segments. A picture on the left is the typical size of the graft. Now, this is a very large graft. It allows for a large area for bone to grow across. So the goal of this procedure is to achieve a fusion or growth of bone between the superior and inferior vertebra. And usual incision is on average about 2 inches in length. We'll talk about a couple of the cases, the patients that demonstrate this technique. The first woman is a 62-year-old female. She presents with approximately 3 years of severe back and leg pain. Pain is present with sitting and with standing. The distinguishing feature of spondylolisthesis is that there's a great amount of back pain, and usually the pain is not dramatically relieved with sitting down. She had no improvement with traditional therapy. Of note, she had a prior posterior procedure at L4-5 where traditional posterior lumbar fusion performed at UCLA. She was referred here for a higher level of care, of course. Of note, she initially had improvement after her first surgery. These are the preoperative MRI and postoperative immediate X-rays after her surgery at UCLA. You can note there's mild to moderate stenosis at L4-5 and a grade 1 spondylolisthesis at this level. The surgeon did a good job performing the fusion with posterior screws and grafts in between the vertebrae. However, posterior procedures do have a known complication rate of developing disease at adjacent levels, and that can be as high in literature as 10 to 15% in certain cases. And this is exactly what happened in this patient. So at just 3 or 4 years after the surgery, she presented with a solid fusion at L4-5, but now she's developed instability and a spondylolisthesis at the level above that fusion. You can see at L3-4 she's got a slip vertebra. MRI of the spine at that level, a T2 image of the sagittal and axial cuts reveal the spondylolisthesis on the right, but in addition you can see that there's a large bulging disc causing moderate to severe stenosis centrally. Now, there's a dilemma of what to do with the patient with this problem. Going anteriorly would require significant dissection and mobilization of the aorta and the vena cava. It is harder to do at the higher up in the spine as there are more segmental vessels. And in addition, a posterior procedure would require a large surgery because the screws and the hardware that are already present there would have to be removed or replaced. In addition, there would be a lot of scar tissue from the prior surgery. So this patient underwent a direct lateral fusion, where through that procedure that we talked about, a graft was placed on the picture on the right. You can see a graft. It's secured by 2 screws to the bone. What you can also note is that there's nearly complete reduction of the spondylolisthesis, and the back of the vertebra of L3 and L4 nearly completely line up. And the patient was in the hospital for approximately 2 days and was discharged with no back or leg pain. Another patient is a 37-year-old male presented with symptoms of back and leg pain. Again, a failed conservative treatment. He had previously undergone a microdiscectomy, which is a fairly common and straightforward procedure in spine surgery, approximately 3 years ago. At that time, his surgeon was very aggressive and performed a nearly complete discectomy. He had removed nearly most of the disc. As a result, the patient was left with a severely advanced degenerative disc disease. If you look at the disc space, the space between the vertebra at L4 and L5 compared to the spaces above and below, it's severely diminished, and it's nearly bone-on-bone disease. In addition, when the disc space is collapsed like this, it causes stenosis of the neural frame and compared to the levels above. And this is where most of his symptoms were. On the MRIs, the sagittal and axial spine, again, you can see there's significant room centrally, but on the right side, there's severe subarticular and foraminal stenosis. This patient underwent a direct lateral fusion as well. through a minimal invasive approach. The disc was completely removed and a spacer was placed. It allowed for distraction between the two vertebrae at L4 and 5. He was in the hospital for about 1 day, and he was able to return to work as a truck driver within 2 weeks after surgery. So in conclusion, lumbar spinal stenosis is a degenerative condition. It results in compression of the neural elements, and symptoms of leg and back pain, weakness, and numbness can develop. Patients who have failed conservative treatments, newer minimally invasive procedures, such as minimally invasive decompression and the X-stop procedure, offer a means to relieve the patient's symptoms. The newer procedures, such as minimally invasive A-lift and X-lift, provide remarkable benefits and quick recovery to full function. Thank you. Yes, sir.
I'm curious the approach that there would be in somebody who's previously had a compression fracture or a kyphoplasty, either with X-lift, A-lift, or any of the procedures in those kinds of patients. Can they be done?
Once the fracture is healed, traditional spinal procedures can be done. The downside of a patient that has required kyphoplasty is that patient is already osteoporotic, so that puts them at a disadvantage for spinal fusion surgery. Fusion surgery requires placing grafts and screws into solid bone. So if the bone is already weakened, there's a much higher risk of poor outcomes, post-operative fractures, or failure of surgery in patients that have weak bone. For patients with advanced osteoporosis, a lot of times we try to abstain undergoing fusion procedures and do more traditional laminectomy or X-stop procedures.
Where does a bilateral foraminotomy come into this picture?
It's part of the traditional laminectomy. So during laminectomy, a foraminotomy can be performed at the same time. And it does increase the space of the foramen by removing some of the bulging disc and some of the osteophyte. But if the foramen is very collapsed from a degenerated disc, you cannot restore the height or the overall area of the foramen with a foraminotomy as much as you could by directly distracting or increasing the space through it.
By pushing the space up, you increase the
Correct.
diameter of the foramen.
Correct. Yes.
On several of the slides from both of you, you indicated that conservative management, including physical therapy, which failed or would worse, would be the indication of conservative physical therapists that would be experienced as to what kind of therapy the patients are administering. Decided that they would have surgery. Some of the newer research actually including Spondylolisthesis, Stenosis, and so on, is dependent somewhat upon and also be able to help. And if that was not addressed, then possibly the physical therapy would not be effective. Comments on?
I basically agree that.
I'm also a visitor here, so.
Well, you're welcome to teach all of our physical therapists how to do this correctly. No, but all patients should have certainly strengthening program. They should have and address any issues that the therapist feels they can help them. But typically, I send my patients for a back strengthening, pelvic stabilization program, abdominal strengthening. By unload, you can dynamically, as you know, unload your back by strengthening the muscles around the back. And to me, that's the best conservative option that the patient has. You need to unload your spine in some way, and you either do it dynamically or weakly. So I encourage all my patients, no matter how old they are, what their pathology is, to have an aggressive back strengthening exercise program. And that's what they can do to make themselves as good as they can be, and then we take care of the rest.